We're going to move along to the lymphatic system. The lymphatic system is going to be our shortest system for this entire semester. So what is our lymphatic system? Our lymphatic system serves two primary functions, but both of those essentially are to help another system do its job. So it assists the immune system and the cardiovascular system. It helps out the immune system by transporting and storing immune cells, lymphocytes, other cells that help to defend our bodies against pathogens. So it's kind of storage space and transportation for a lot of those immune cells. And then it helps our cardiovascular system by returning fluid to the cardiovascular system to help us maintain our fluid balance and our blood volume and our blood pressure and all of that. So whenever fluid is in our plasma, in our cardiovascular system, if the pressures are just right, so we've promoted filtration, some of that fluid can leave the blood vessels and get filtered into the interstitial space. From there, it can either move back into the cardiovascular system if it gets reabsorbed at the venous end, or it can move into the lymphatic system. So some of that filtered fluid can move into the lymphatic system. The lymphatic system can then hold it, or it eventually puts it back into the cardiovascular system, again, to help maintain fluid balance, blood volume, and then blood pressure. So what is lymph? This is basically what I just said. About 15% of the interstitial fluid does not get taken back up into the blood vessels, but rather it goes into those lymphatic vessels, and then as soon as it's in the lymphatic vessels, it's referred to as lymph. It's composed primarily of water with dissolved solutes and a very small amount of protein. We have these lymphatic capillaries that are small, closed-in vessels that absorb that interstitial fluid. They're typically, in any anatomy and physiology book, they're usually colored green. Sometimes you'll see yellow. But they're kind of dispersed among the areolar connective tissues amongst the blood capillary networks. The exception here is bone marrow, but typically when you find blood capillaries, you'll see lymphatic capillaries as well. So here is an arteriole, and it feeds into this capillary bed, and you can see the green lymphatic vessels kind of interdigitated throughout that capillary bed, so that any fluid that gets filtered out in these capillaries has the potential to get picked up in these lymphatic vessels. So there's no lymphatic capillaries in avascular tissue such as epithelia. If they're avascular, meaning there's no blood vessels. If there's no blood vessel distribution, there's not going to be lymphatic vessel distribution either. The vessels are composed of these overlapping endothelial cells that allow a way for the fluid to enter the vessel but not come out. So essentially what happens is they kind of overlap, and then as the fluid comes in, it stretches and stretches and stretches the vessel to where they're less and less and less overlapping, and that kind of pulls them tight a little bit. And then once they're pulled tight, the fluid is trapped in that vessel. And it's not going to flow out. It's going to flow through the lymphatic system, which eventually empties into the cardiovascular system. But once the fluid comes into those endothelial cells, it's not simply going to diffuse out. Then another thing that you'll see are these little anchoring filaments. Anchoring filaments help to anchor the lymphatic capillaries to other structures. So they just kind of attach to the vessel and then to the tissue space around there to just kind of anchor that where it's supposed to be. The movement of lymph into lymphatic capillaries. So as you have this increase in hydrostatic pressure within the interstitial space, increased pressure pushes that interstitial fluid into the lymphatic capillaries. So let's look at this diagram here. Here's our arteriole. We have high hydrostatic pressure here at the arterial end of the capillary bed, so we get filtration happening, and that fluid is going to build up a pressure outside of the vessels. That's that interstitial pressure, and that promotes the movement of that fluid into the lymphatic capillaries. And so once it's in there, it's lymph. The increased pressure within the lymphatic capillaries that happens as a result of that fluid moving into them forces the endothelial cells of the vessels closed, thereby trapping the fluid. So basically, as more and more fluid comes from the interstitial space into the lymphatic capillaries, the lymphatic capillary fills and fills and fills and kind of stretches it nice and tight to where the fluid can't get back out. So then what happens is the lymph is going to be transported through this network of vessels that's going to increase in size. So we're starting with the lymphatic capillaries that are here in the kind of interdispersed with the capillary bed, and then from there it's going to go from the capillaries to larger lymphatic vessels, to larger lymphatic trunks, and then to larger lymphatic ducts. So you can see this kind of tells you the order from small to large: capillaries, vessels, trunks, and ducts. And this kind of tells you the movement of the fluid based on the changing pressures. We have high pressure in the blood capillaries, so that causes the fluid to move out. It gets into the interstitial fluid. From the interstitial fluid, it's going to make its way into the lymphatic capillaries, and then once it's in there, again, it's going to be trapped in that vessel. Remember, it's not going to diffuse out back into the interstitial space. So from the lymphatic capillaries, it will start to just go through the lymphatic system, moving from the lymphatic capillaries to the veins or vessels, to the ducts, to the trunks, and then to the ducts. So we should put lymphatic trunks right here. And then to the large circulatory veins. So it's going to basically dump back into the cardiovascular system. So metastasis is one of our clinical views. So this happens sometimes when cells from a primary tumor can break off and they enter the lymphatic vessel. The lymphatic vessel travels essentially anywhere that our blood travels, which is a lot of different places. So if it gets into the lymphatic vessel, it can travel through the system to a secondary site. And then you could potentially, if that cell starts to grow and develop in that secondary site, then you have a secondary tumor. This can also happen in the regular circulatory system. So if you have a primary tumor, you have one single tumor in the body, and a cell or two cells or a handful of cells breaks free. If it gets in the lymphatic system or if it gets in the blood circulation, either way, it can travel to a distant side of the body and start to grow a secondary tumor there. That's called metastasis. That's when your tumor has metastasized. So just some of the terminology down here in the second sentence. If a breast cancer tumor has metastasized to the lungs, the lung tumor is now referred to as a quote-unquote metastasized breast cancer. It's not lung cancer. It's not lung cancer because it didn't start in the lung. It doesn't have the features of a lung cancer tumor. It's a breast tumor because that's where it's originated. It just relocated or metastasized to anywhere else in the body, in this particular case, the lung. So let's look at the lymphatic vessels. The lymph from the lymphatic capillaries is going to flow into the larger lymphatic vessels. The lymphatic vessels are very structurally similar to the veins in that they have all three tunics. They have the tunica intima, media, and externa. They also have valves to prevent backflow. The lymph is moved throughout the vessels by the skeletal muscle pump. We saw that when we talked about how blood moves through the veins and the limbs. The respiratory pump, we saw that as well, and how the blood moves back to the heart and the veins in the abdominothoracic region. Pulsatile movement of blood in the nearby arteries. So you have a little bit of a pulsating force as blood goes through the arteries, and so that can help push fluid through the lymphatic vessels, and the rhythmic contraction of smooth muscles in the larger lymph vessel walls. So we have smooth muscles surrounding some of our larger lymph vessels, and as that muscle kind of contracts, it can help propel the lymph through there. Some of the lymphatic vessels connect directly to a lymph node. The lymph node is kind of like a little stop check session. It's a place where we have certain cells, certain immune cells, that kind of take a look at the lymph as it passes by, and it filters out anything that shouldn't be there. So it's just kind of like it's like a checkpoint. As the lymph passes through, we kind of look at it. Is there any bacteria in there that shouldn't be there? If so, let's clear it out. Is there anything in there that indicates that we have any kind of infection or tumor or anything that shouldn't be in our body? And if so, we will start the process of initiating an immune response against whatever we see. So just little checkpoints are those little lymph nodes, and they just kind of lie along the path of lymphatic vessels. The lymphatic vessels will eventually feed into lymphatic trunks. We've got them on both the left and the right side of the body, and each lymphatic trunk is responsible for removing lymph from a specific region of the body. So you have your jugular trunks. Those drain lymph from both the head and the neck. Subclavian trunks remove the lymph from the upper limbs, the breasts, and the superficial thoracic wall. The bronchomediastinal trunks drain lymph from the deeper thoracic structures. The intestinal trunks drain lymph from most of the abdominal structures, and then your lumbar trunks remove lymph from the lower limbs, abdominal pelvic wall, and then the pelvic organs. So different trunks, again, on both sides of the body, removing lymph from the smaller vessels from these different regions: head and neck, upper limbs, breast, and superficial thoracic structure, and then deeper thoracic structures, abdominal structures, and then basically everything below that for the lumbar trunks. So from there, we're going to go into the lymphatic ducts. So the lymphatic trunks that we just talked about, draining region-specific areas of the body, will drain into one of two lymphatic ducts. These are the larger ones. So you have two of them, the right lymphatic duct and the thoracic duct. So it's a little tricky because you've got the right lymphatic duct, but then you don't have the left lymphatic duct. That doesn't exist. It's right lymphatic duct and the thoracic duct. So the right lymphatic duct receives lymph from the right side of the head and neck, the upper right limb, and the right side of the thorax. It's essentially the upper right quadrant of the body. So everything in green on this guy is drained by the right lymphatic duct. It's going to return the lymph at the junction of the right subclavian and the right internal jugular veins. So you can see right here, it's kind of hard to see in this picture. I think I have it larger somewhere else, but it's going to dump right there where the subclavian meets the internal jugular veins. So earlier I said that the lymphatic system drains directly into the cardiovascular system. This is where that happens. It's just going to dump it into the veins, and we know the veins are going to take it back to the heart. The thoracic duct is the larger of the two ducts. It receives lymph from everywhere that I didn't just describe. So it's going to be the left side, the whole left side, the abdomen, the lower limbs, everything that's not in this upper right quadrant. At the base of the thoracic duct is a sac-like structure called a cisterna chyli. So you can see that here. The cisterna chyli receives lymph from vessels that drain the small intestine of the GI tract. So all the vessels that are draining the small intestine are going to drain first into the cisterna chyli, and then that is going to ultimately drain into the thoracic duct. And you can see where the thoracic duct is going to join that subclavian and internal jugular right here, just like we saw on the right side with the right thoracic duct. So here's just all of that a little bit larger. The right lymphatic duct is all of this that's in green. That's what's drained by that duct. Everything else is drained by the thoracic duct. You can see the thoracic duct right here. Here's that cisterna chyli draining the lymph from the vessels of the small intestine. And then again, it's going to go up. And if we're talking about the thoracic duct, it's going to empty into the junction of the left subclavian and the left internal jugular vein. So all this right here. If we're talking about the right lymphatic duct, it's draining into the right subclavian, right internal jugular, right there. These little dots that you see along, they look like little peas. Those are lymph nodes, just kind of interdispersed on the pathway of lymphatic vessels. Another clinical view is lymphedema. Lymphedema is when you have an accumulation of that interstitial fluid. It usually happens as a result of an interference with lymphatic drainage at a specific body part. So remember, we get fluid that's leaving our blood system, goes into our interstitial space, and that can get picked up by the lymphatic system. If it's not picked up by the lymphatic system, some of it might get reabsorbed into the blood, but if it doesn't, it's just there sitting in that interstitial space. And that's where you're going to get that swelling and that edema. The accumulation of that can cause pain because it starts to push on pain receptors. There's not supposed to be stuff collecting there. So it pushes on receptors that would otherwise not be activated, and that causes pain. And of course, swelling, because you've got all the fluid build up there. If it's not treated, it can interfere with wound healing because you have all of that excess fluid serves as a great growth media for bacteria. So it's just sitting there and it's stagnant and it's not moving anywhere. And if a bacteria finds its way there, it's going to think this is a great place to grow, and it's going to replicate, and then you have an infection in that swollen area. So this can be caused by an obstruction in the vessel. So if you've got scar tissue, some kind of vessel damage, or a tumor cell blockage, so the lymphatic vessel is just kind of blocked and it's not allowing fluid to come in and move freely. There's not actually a cure for this, but it can be managed if you use compression socks or massage or certain exercises. And basically the goal is to move the fluid to an area that doesn't have a damaged or a blocked vessel. It doesn't have to go into the lymphatic system right there where it's at. That normally is what happens because under normal circumstances it can. But if we can move and manipulate that fluid to an area where there's lymphatic vessels that are not damaged, then it can go into the lymphatic system there, and then we've essentially cleared it out of that area. So our lymphatic tissue and organs are classified as being either primary or secondary. Primary lymphatic structures are specifically involved in the formation and the maturation of our lymphocytes. The bone marrow and the thymus are the only two structures that are considered primary lymphatic structures. All of the rest are considered secondary lymphatic structures, and they're not involved in the formation or maturation, but rather the housing and the storage of the immune cells. So our secondary lymphatic structures are going to be your lymph nodes, your spleen, tonsils, lymphatic nodules, and what we call MALT, which stands for mucosal associated lymphoid tissue. So we're going to talk about all of those as we go through. But functionally, the difference between primary and secondary is primary is when that tissue is involved in the development and the maturation of the lymphatic tissue. The development and the maturation of the lymphocytes. And then secondary is the storage and housing of the lymphocytes. And again, bone marrow and thymus are the only two that are primary lymphatic structures. Let's start with red bone marrow. Red bone marrow is located between the spaces of the trabecula within spongy bone. So in adults, that's going to be found in the flat bones of the skull, the vertebrae, the ribs, the sternum, the os coxa, or those hip bones, and then the proximal epiphysis in the humerus and the femur. Red bone marrow is the site of hemopoiesis. Remember that term from the blood chapter where we form lymphocytes here, form blood cells. So in this case, it's T lymphocytes are being formed during hemopoiesis, and then they have to migrate to the thymus for maturation. So remember I said those primary lymphatic structures are involved in the formation and maturation of lymphocytes. So we're getting T lymphocyte formation in the red bone marrow, but it's kind of like this immature version of a lymphocyte. So here you can see it says pre-T lymphocyte. So it migrates from the red bone marrow down or up or wherever to the thymus, and then it sits in the thymus And at that point, it matures into a mature T lymphocyte. And then after that, it can go into the circulation. So the thymus is this bilobed organ. It's located in the superior mediastinum, so it's this kind of central located in the upper thorax, and functions in T lymphocyte maturation. The thymus is pretty large in infants and in young children, and it continues to grow until puberty. At puberty, it starts to regress. So from puberty on, it starts to get smaller and smaller and smaller, so that adults actually have very little thymic tissue remaining. It's two fused lobes surrounded by a capsule that has these extensions called trabeculae that project inward to subdivide the different lobes into lobules. So we'll see these trabeculae over and over when we look at lymphatic structures. So if this is your thymus here, this is the capsule, this outer layer. And notice how it projects inward right here. That's your trabecula, where it projects inward here. And so it just kind of divides it into these different lobules. You can kind of see in this image as well the little inward projections that are trabeculae. Each of the lobules has this outer cortex area. The outer cortex contains immature T lymphocytes, or those pre-T lymphocytes. So this area would be your outer cortex here. And then there's an inner medulla inside here that contains mature T lymphocytes. So we'll see some of these terms that we've talked about for the thymus will come up over and over. Trabecula is when you have the inward projection, so it's deep diving from the outer layer, in this case the capsule, and it just kind of subdivides the tissue into different sections. The term cortex we'll see. A lot of our organs and tissues have a cortex. That's the outer area. It's not necessarily the outermost, because a lot of things have this fibrous capsule. That's kind of the outermost. But just under that you have the cortex. It's the main kind of tissue of the organ, but on the outside of it, or the outer layer. And then the deeper inner structure is the medulla. So here you can see the contrast of the child's thymus, see how large it is, compared to the adult's thymus here. And histologically, here's the thymic tissue filled with actual thymic tissue. And then compare that to the histological section of an adult thymus, where you have little bits of thymic tissue and a lot of adipose tissue in between. That's just kind of our packing material to go between the little bits of thymic tissue that we have. For the secondary lymphatic structures, we'll start with lymph nodes. Lymph nodes are very small, they're round, they're encapsulated structures, and they're located around the pathway of the lymphatic vessels, where they serve as the main lymphatic organ. So your lymph nodes, the function is kind of like what I said before. It's kind of like a checkpoint or a check station. They filter the lymph as the lymph is traveling through those lymph vessels. They can kind of put eyes on, take a look at the lymph that's going in, and filter and remove any unwanted substances that might be in there. You have afferent lymphatic vessels that bring lymph into the node, and an efferent vessel that takes lymph away from the node. You have an involuted portion, and we'll see what that looks like in just a second, called the hilum. The hilum drains the lymph from the lymph node. The capsule of the lymph node has those inward extensions or inward projections called trabeculae that we saw, and those kind of subdivide the node into different compartments. So here you can see the lymph node. Here's the capsule, green capsule surrounding it. You can see these inward projections where it that capsule kind of projects inward. That's called trabeculae. And you can see how it kind of creates these different sections or segments of it. So just deep to the capsule, you have the cortex. So all of this area that I'm tracing here is the cortex. The cortex has many lymphatic nodules. So everywhere you have the trabecula projecting inward and you have it kind of subdivided, this is a nodule. So here's a nodule, here's a nodule, here's a nodule. And then those nodules have an inner germinal center and an outer mantle zone. So this darker outer region is called the mantle zone. And then the inside is called the germinal center. Now deep to the cortex, you have the medulla in here. So this center area is called the medulla. In here you have different strands of lymphocytes. You have a bunch of macrophages. And then you have some supportive connective tissue called medullary cords. And then both the cortex and the medulla have these openings called sinuses. So sinuses are just these openings so that lymph can flow through in one end and out the other, and then be kind of visualized by whatever immune cells are located within the lymph node. The lymph is going to enter through the afferent lymphatic vessels. So you can see some afferent vessels here. Here's one, and here's one. So the lymph is going to come in. It's traveling through those vessels, lymphatic vessels, and it will enter. And you can see the valves. See, it's structurally similar to the veins. So the afferent vessels bring it in. It kind of moves throughout those sinuses. As it moves through the lymph nodes, we're going to continually monitor, look for the presence of foreign material. That could be a bacteria, that could be a cancer cell, a virally infected cell, anything that shouldn't be there. So we're looking for that as the lymph travels through there. If we find something that can be easily phagocytized by a macrophage, we will go ahead and do that. And then the lymph is going to exit through the efferent vessels. So the efferent vessels take it away, and then it'll travel on through some additional lymph vessels, and then again it'll find another lymph node. So it just kind of goes through the whole process. If the lymphocytes within the node do encounter a foreign substance, an immune response will be generated. And basically what that means is we start to undergo multiple cell divisions of a lymphocyte. What we're trying to do is create an immune cell that is able to recognize and attack this particular pathogen or this particular bacteria, so that we can send them out and clear them out of the body. So we get multiple replications of these lymphocytes. It happens in the germinal centers. Some of those lymphocytes will stay in the node, others will go out into the area of the body where the infection is, so we can clear it from there. Swollen lymph nodes are a sign that the lymphocytes are proliferating. So proliferating means multiplying or making more of themselves. So when there is an infection, those lymphocytes start to divide. You have rapid proliferation, and that can sometimes be felt or palpated in those superficial lymph nodes, the ones that are kind of closer to the surface of the skin, because they enlarge as those lymphocytes are replicating. Another clinical view, this time lymphoma. Lymphoma is a malignant neoplasm, or a cancer, that develops from the lymphatic structures. Usually it presents as a non-tender enlarged lymph node in the neck or axillary region. Again, the axillary region is kind of that armpit area. The lymphomas are grouped into two categories. You have Hodgkin lymphoma versus non-Hodgkin lymphoma. So Hodgkin lymphoma is characterized by the presence of what's called a Reed-Sternberg cell. A Reed-Sternberg cell is a large cell, and the nuclei resemble owl eyes. And then it's going to be surrounded by lymphocytes within the affected lymph node. So here's your Reed-Sternberg cell. It's just the way it appears. It kind of looks like two owl eyes. Hodgkin lymphoma affects younger adults, typically ages 16 to 35, in that range. And then again, you have an additional susceptible group for people over 60 years old. It usually starts in the lymph node and then spreads to the other lymph nodes. If it's caught early, Hodgkin lymphoma can be treated and cured by excision of the tumor, so just kind of take it out. followed by radiation, chemotherapy, or both of those two combined. Then you have non-Hodgkin lymphoma. Non-Hodgkin lymphoma are much more common than the Hodgkin lymphomas. These typically develop from abnormal B lymphocytes. So we haven't really gotten into T lymphocytes or B lymphocytes, but we will in the next chapter in the immune system. But typically non-Hodgkin starts from abnormal B lymphocytes and less commonly from the T lymphocytes. Some kinds of the non-Hodgkin lymphoma are aggressive and more often than not fatal, but then you have other kinds that are more slow growing and more responsive to treatment. So what kind of treatment an individual receives is going to depend on the type of non-Hodgkin lymphoma, and then how metastasized is it, how spread out is it throughout the body, and then how far along the patient is when it's diagnosed. You know, with any cancer, the earlier you catch it, the better your chances are that it's going to respond well to treatment. Moving on to the spleen. The spleen is our largest lymphatic organ. It's located in the upper left quadrant of the abdomen, so you can see it. It's kind of almost like see-through or invisible, but you can kind of see it over here in this diagram. Here's what it looks like, and then you can see it here as well, upper left quadrant. The spleen's posterolateral aspect is convex, so it has almost like a bean shape. It's kind of convex over here. And then concave on the anterior medial border. That's where the hilum is. So the hilum we'll see in a couple of our lymphatic structures. I think I mentioned I was going to point it out on the lymph node, and I'm not sure that I did. So you might go back to the lymph node slide. But basically you'll see this indented region. That's where a lot of the vessels will come in and out, and that's the hilum. So hilum is always kind of this indented region. And more often than not, you have vessels and nerves and everything coming into that structure at the hilum. So we have a splenic artery that delivers blood to the spleen, and then you have a splenic vein that is draining the blood away from the spleen. The spleen is surrounded by a connective tissue capsule. It does have those inward projections called trabeculae. In this case, instead of dividing the spleen into nodules, it divides it into red and white pulp. So the spleen phagocytizes bacteria, foreign materials in the blood, and old defective erythrocytes and platelets that are circulating in the blood. So remember, our erythrocytes only have a limited lifespan because it's a formed element. So we're constantly making new ones. So the ones that are kind of past their prime can get phagocytized and cleared out in the spleen. The spleen also serves as a reservoir for platelets. So this is a case where we kind of store platelets so that in some kind of hemorrhage situation, we've got an active storage that we can release to start promoting blood clotting. The white pulp of the spleen contains T lymphocytes, B lymphocytes, and macrophages. And then you have what's called a central artery. So here's a look at the white pulp. You can see the central artery right here, and then you've got lymphocytes and macrophages residing there. The red pulp has red blood cells or erythrocytes, platelets, B lymphocytes, and macrophages. The cells of the red pulp are stored in this reticular connective tissue, and they form what's called splenic cords. And then they also have sinusoids, which are those capillaries with the big chunks taken out. And that's important to have in the spleen because remember, the spleen is where we're going to clear out red blood cells. Those red blood cells would not be able to exit the circulatory system if it weren't for those sinusoidal capillaries. We have to have those big chunks taken out for the erythrocytes to pass out and get phagocytized. The platelets stored in the red pulp are what we use as our reservoir in case of hemorrhage. So we store those platelets in our red pulp. So the pathway of blood as it goes through the spleen, it comes in the splenic artery. From the splenic artery, it goes into a central artery. We saw that central artery located in the white pulp. From there, it goes on to the sinusoids of the red pulp. As it travels through the sinusoids, the macrophages will phagocytize any bacteria, foreign materials, or anything that shouldn't be there in the blood. It will phagocytize that. It will also get rid of any old and defective erythrocytes and platelets. From there, the blood's going to drain into the venules and then out of the splenic vein. So the general flow again is splenic artery, and then the central artery, which is located in the white pulp, and then the splenic sinusoids, which is located in the red pulp, and then the venules, and then ultimately the splenic vein. The tonsils are also a secondary lymphatic structure. These are located in the pharynx. They help to protect against foreign substances that have been inhaled or ingested. You see where they're located. You can see why they make a good defense mechanism for anything that could come in through the nose or the oral cavity. So they have these invaginated edges called tonsillar crypts. So it's basically a folding pattern. Anytime any of our body structures are folded like that, it's there to increase the surface area. And that's having a high surface area is good because it allows us to kind of catch more things. So the tonsils contain what are called lymphatic nodules. You've got the pharyngeal tonsils located in the posterior wall of the nasopharynx. So way up here. So posterior wall of the this area right here is the nasopharynx. We're looking at the kind of the back area of that. Palatine tonsils are located in the posterior lateral wall of the oral cavity. So you can see them here. You can also see them here, palatine tonsils. And then the lingual tonsils are located along the posterior aspect of the tongue. So kind of all in that kind of throat pharynx region, you've got the three different types of tonsils. And again, tonsils are secondary, and they're there to kind of act as a defense mechanism or to catch anything that we don't want that we either inhaled or ingested. Acute tonsillitis is an acute infection or inflammation of the tonsils. So the palatine tonsils are the ones that are going to be more commonly affected with tonsillitis. They get very red, they swell up, they get enlarged. They can get so large that they can actually partially obstruct the pharynx. So here you can see very red and enlarged palatine tonsils. Here. They can become infected by a virus or bacteria, so you can get fever, sore throat, difficulty swallowing as those tonsils enlarge. Now, chronic tonsillitis is when you have very persistent and recurrent infections. So if it just happens every once in a while, it happens once, or you get it again a couple years later, those are situations of acute tonsillitis. When it comes back over and over and over, that's considered chronic tonsillitis. And if that happens, it could call for a tonsillectomy, where you go in and actually remove the tonsils. So lymphatic nodules in general are small oval clusters of lymphatic cells with some extracellular matrix. We've got these scattered throughout the body. They can be found in every organ and in the walls of the appendix, and they help to defend against infections in the different structures. So they're just kind of like little clusters of lymphatic and immune cells kind of spread throughout, so that if a bacteria or a pathogen or anything that should not be in our body makes its way to that structure, we have some cells there situated ready to go. Now, if a larger infection happens, of course, we're going to launch an entire immune response that will be covered in the next chapter, and send additional cells that way. But at least we have a few immune and lymphatic cells situated in these lymphatic nodules throughout our body, so we at least have something there to kind of monitor, detect, and attack or phagocytize anything that's in that structure that shouldn't be there. So in some area of the bodies, you have lymphatic nodules that group together to form larger structures, and our MALT is an example of that. MALT stands for mucosal associated lymphoid tissue. Mucosal associated lymphoid tissue is located in the mucosal layer both in our GI tract, our respiratory, and our urogenital tract to help defend against any pathogens that come in contact with those mucous membranes. So if you look at all of those things, the GI tract, the respiratory tract, the urogenital tract, those all have an opening to the external environment. That makes those areas very susceptible for pathogens because they can easily come in as we eat food or we breathe in or anything like that. So one way that we protect those systems or those structures is to create this mucosal lining. And there's a variety of different things in the mucosal lining that help to protect against pathogens coming in. But one of those is the mucosal associated lymphoid tissue. So we'll just stick those lymphatic cells and immune cells right in that mucosal layer to help catch anything as it may come in. Now that MALT, or mucosal associated lymphoid tissue, is very prominent in the small intestines, where we have these larger collections of lymphatic nodules, and we call them Peyer's patches. So Peyer's patches are specifically the MALT that is located within the small intestines.